Let's transition to something that I actually think is one of the most exciting things we've had in the past 5 to 10 years in lung cancer, and that's moving immunotherapy up to stage 3 disease. And we saw the recent results of overall survival in the PACIFIC trial. So Suresh, I'm going to ask you to kind of walk us through PACIFIC and get your thoughts on, is it the new standard of care? And from a radiation oncology point of view, how do you see this data?
So I'd agree, it's an exciting development. Standard chemoradiotherapy and patients not progressing, getting durvalumab or placebo, 2 in 1 fashion. It was very encouraging to see the OS readout, so with a hazard ratio of 0.68. So that's really very impressive. And the PFS has been maintained. That's good. And I think there were some concerns about the trial, but it's reassuring that there are no safety issues, especially for lung, as we do the follow-on. And interestingly, it's also important to note that the standard arm, the median overall survival has come out within the range we would expect, because that was a concern in the past.
28 months, right?
28.7 months or something like that.
Yeah, I mean, it was
so it's not Duva is not looking good because of underperformance in the standard
If
arm.
anything, it was better than we would have anticipated, yeah.
So, and the other thing that's interesting to me, but the presentations at the World Congress didn't really shed all that much light, is can we explain why the hazard ratio is much more favorable when we give it within 14 days?
Right.
Is it because the smaller tumors, there's less collateral damage and less recovery time, and smaller tumors do better? Or is it because of some other biological factors which we do not know about? Right,
there's some magic to giving it early.
It seems to be. If you look at the animal data, it's more advantageous to give it as close as possible.
Yeah.
But I think that's something that in clinical practice we're trying to see whether we can actually shorten that gap, because it seems to be, in this context, with a PD-L1 inhibitor, it seems to be important.
Yeah, and it was the one thing I want to get back to and just get your comments on. I mean, obviously one of the concerns of PACIFIC was there going to be any interaction with regard to pneumonitis, realizing that radiation pneumonitis is an issue, immune-related pneumonitis is an issue, and I think the data from PACIFIC were really reassuring that we aren't exposing patients to undue risk in that setting.
Yeah, I would agree with that. The grade 1 and 2 pneumonitis
was a little higher.
A little higher, especially in the East Asian populations. But in the rest, it was very reassuring. And high grade, grade 3, 4, and 5 is very manageable.
3%, but it was 3% on placebo also.
Exactly.
One of the things we don't know from that data is, or at least I don't believe we know, is the DVH data with regard to dosing of the lung and that sort of thing. So I don't know that was collected.
I think some of the data has come out, but it's in an international global trial with so many patients. I think it's incomplete. I mean, what did they treat? I mean, that's what the community is looking for. Who was not treated?
Right.
And who didn't come true to the randomization?
Right.
So I think it just means that we need more and better designed trials to try and tease out some of these factors. And of course, the biomarker issue you've touched on in advanced disease, I think in local disease, that's really a hot topic with the new...
Max?
But what I really liked in this PACIFIC trial, that it's real-world data nearly, because it was not a special chemotherapy, special radiotherapy technique. It was just like we really do it, and it showed these great results. And I think what is new with this trial also, before we just tested PD-L1 staining for patients in stage 4, now we have to put that also in early stages. And now we are testing PD-L1 also for those patients, because we saw the real good result for the PD-L1 staining patients.
Yeah, so one of the things that's kind of interesting to me is, getting back to the data that suggests that the sooner you give durvalumab after completion of chemorads, the better off it may be. At least in the United States, there's been this reluctance to give up consolidation chemotherapy, which is surprising to me, because we were never convinced that either induction or consolidation really made a difference. But somehow people got kind of wedded to the idea that you had to give consolidation. I actually like induction, and PACIFIC has, in my opinion, given me permission to give induction therapy, since 28% of the patients on PACIFIC did get induction, and I believe that stage 3 is still kind of, in my mind, as a medical oncologist, a 4-cycle disease. We have to give an adequate systemic exposure of chemotherapy because we're dealing with local regional disease as well as micrometastatic disease. And so that's kind of my bias, although I will admit I can't prove that one way or the other. Comment?
Absolutely, I'm completely in line with you. For me, it was strange.
I knew you were a smart guy.
Yes. For me, it was strange that you start IO immediately after radiotherapy.
Yeah.
That's when I gave the first patients before the publication in Toronto, the immunotherapy. I said, let's take some time, 2-3 weeks. We meet each other, then we plan the whole thing in the named patient use programs. But now I really start. After the day the patient is ready with radiotherapy, the patient is coming for durvalumab in this situation. I think this is a completely practice-changing study.
Yeah, it's interesting. I heard something recently, and I can't reveal my source on this, but it was the percentage of patients with stage 3 disease that get no therapy in the U.S. And I think, historically, we've had a lot of therapeutic nihilism associated with lung cancer. And, to me, seeing this data provides a really heightened level of enthusiasm to make sure those patients get treated. Is that, others have that same feeling, or?
I think it does improve the stage 3 and the popularity of this therapy when you start seeing these really prolonged survivals. And then I think the other thing about Pacific, the time to distant metastases was floridly positive. So it's really an effective systemic therapy.
I personally did not need the overall survival curve that we saw at World Lung. When I saw the either time to death or time to first metastasis, which to me is a poor man's Kaplan-Meier overall survival curve, because what we're trying to do with chemoradiotherapy is to prevent stage 4 disease and prevent death. Yes. And if you had that, I think the hazard ratio for that initially was close to 0.5. That to me was enough to say there's got to be a survival advantage. Max?
And it's a systemic effect.
Yeah.
This, and this is a strong announcement.
Right. Yeah. Right.
I will say one thing, though, that Max mentioned. In the U.S., the restriction is not based on PD-L1 status.
Right.
Yeah.
Yeah.
So we actually...
That's right. That's right. It's a good point.
We don't test our patients often in early stage. So sometimes we don't even know. The argument being that if they recur, you're going to biopsy them anyway, and you'll find out at that time. And with the metastatic data, PD-L1 has never been that great in predicting responders versus non. So in the U.S. at this time, it's, we can't say sometimes you should use the data because the subset analysis was positive, and then sometimes don't use it when the subset analysis is negative. Right. So it's not restricted at this point in who you can give the drug to.
But I think in Europe it is.
Yes.
I'm completely in line with you, because only in 60% of the patients we could get PD-L1 staining. So it's not very practical. Even it's a real-world study with highly educated centers, and they just got in 60 or 65% of the patients really the PD-L1 staining. So I think your way is much, much better, that we don't really need it in those who are negative. We didn't do something wrong. So the US way is, but it's our label, so we have to do it.
Yeah.
I think I have some hesitancy. We check for PD-L1. I don't know how to apply it because we do it in everyone, but I think I have some hesitancy of foregoing this therapy for a dubious biomarker and then this small subset where maybe prognostic factors weren't balanced. And I think we are treating with curative intent, so the threshold to abandon a therapy, it needs to be high.
I have abandoned induction, though. That may make me less smart. We were doing Cystotope, and the weekly carbotaxol, those patients couldn't tolerate Cystotope.
Right. No,
I have abandoned induction, I will say that.
Yeah, no, if you're using full dose Cystotope, I'll give you that one. But, I just have a hard time in a good performance status PS 0 to 1 patient where the goal is cure of giving just 6 weeks of low-dose carbotaxol as their only systemic exposure. Now, maybe you can get away with that if you use immunotherapy afterwards. Yeah. But, we actually like induction. It takes the pressure off getting the radiation plan done. You kind of got 6 weeks to do it. There's almost always some degree of volumetric reduction. And my colleague here to the left did publish a paper years ago suggesting that pre-radiotherapy volume is a predictor of long-term survival. Volume is important with regard to radiation therapy.
Although Everett's study of induction carbotaxol was not really positive.
No, I understand that, but I will also say that I'm not sure you lived through Everett's study. But I
I've read
did.
it, though.
Yeah, you've read it, yes. But I don't take CLGB3 9801 as the true test of induction therapy. It was woefully underpowered, and I will tell you that there was a 2.5-month difference in median survival that did not achieve significant difference, but the statistical design was looking for a 40% increase in overall survival. So it was a big, big hurdle to overcome. But thank you for bringing that trial.
So we also look back at that trial. The median survival in both arms was
terrible.
Poor. So
Yes.
I mean,
No.
it was-
And I will tell you that, you know, and now I'm going to be on record, there were many people in CLGB at the time that would not put a good performance, you know, a good candidate for chemoradiotherapy on that trial because they didn't want to have the patient just get 6 weeks of low-dose carbotaxol. And I was one of those people.